Michael here for Asymptote Coaching and Wasatch Fitness Academy. Thanks for tuning in. Let's get into this. So today I'm talking about pain and really what I mean as a strength guy by a non-clinical approach to pain. So there's three main pieces of this content. First, I'm gonna give you a little bit of my backstory and literally, my backstory. Secondly, get into a couple of disclaimers. And then third, actually tell you how I think about pain when I'm working with clients. And I give you this as honestly a hope that you will take these ideas and put them into practice as well, and that you will take ownership over your experience. Because that is the single biggest thing that I have seen work well for people. So here's my, again, quote unquote, backstory. So 2012, I was coming home. I was with my then girlfriend, now wife, soon to be baby mama. And we were walking home from the metro station. We'd been out at our climbing gym living in DC, and I'd taken a skateboard to work with me that day. So I was skating, and but I was going at a snail's pace, right? I was skating at the rate she was walking. Front wheel got caught in a crack in the ground, went over, it fell onto my right hip. It hurt for several weeks. I went to a PT. It still hurt for several weeks after time with her. She sent me to an ortho. Ortho had ordered an MRI and diagnosed me with a low back fracture and a slight displacement of a vertebra. Pretty big deal. And he said, hey, you're done skiing, you're done cycling, you're done running. Like you're definitely done with CrossFit. All these things are off the table. So it was about 6 months before we moved from DC to Salt Lake City. We moved out here that winter. I definitely took time off training. We got it here and I was like, enough of this. And I started exercising again, and I got back into CrossFit, and I had a couple of incidents where my low back got a little tweaky. So I went to an orthopedic surgeon here in Salt Lake City, and he redid the MRI and actually did a much better job of explaining to me what was happening. And there's an important lesson here about that too. But he also didn't want to tell me no, right? The message that I took from him was, look, if something hurts you, don't do it. If you predict it's going to hurt you, don't do it. Don't take unnecessary risks, but also don't cut yourself off from things that you enjoy, right? You do need to be strong. You need to be doing strength work. You need to be doing mobility work. You need to be making sure that your body is moving well and feeling good. But if you do those things, you can probably avoid surgery, save some catastrophic accident, right? And something could always go wrong catastrophically. So what that means is my low back is well managed, right? I wouldn't use another word for this. It's not healed. The damage that's there, the fracture that's there, it might have been there since birth actually. That's still the case. So does it limit me a little bit? Yes, to the degree in which there are decisions that I make because of that. I have decided that I am never going to be downhill mountain biking is never going to be my jam, right? High speeds, high potential for impact. That is just not my jam. Luckily, I'd rather ride trail. I'd rather actually pedal a bike than do that. So it's it aligns. But there are other things like skydiving. I really enjoy skydiving. I've thought about getting my license. The impact with the ground is more impact than I'm willing to subject my low back to. The risk reward there is just the analysis is way out of scale. Could I probably do it and be fine? Absolutely. And could I have good enough technique? But the problem is it probably only takes one landing of bad technique for that to be really bad and catastrophic. I have no desire to go there. So that's the way in which it limits me, right? Honestly, not a whole lot. There's some fringe stuff that I decide to not do. Bungee jumping, also on the off list. So there's my backstory, again, literally and figuratively. But what the messages that I hope you take away from that are, first of all, that it's really important to take ownership of the experience. And rather than using an orthopedic surgeon or a physical therapist or as a strength trainer as the solution, all of these people just have information. We're all tools, right? And if at some point I need surgery, then surgery is a tool. When I went to get an MRI, the MRI was a tool. It wasn't the diagnosis. It was just information that could then be fed into the system. And over the course of the years, I have owned more and more of that system. So now if something goes wrong, I may go to a physical therapist, an orthopedic surgeon, I may go to another movement coach and ask them, like, tell me what you see and give me your ideas. But then I take what they see and I take their ideas and I blend that into my own system. And if they're 100% right and it's a scope of practice that I know nothing about, I'm going to follow their guidelines. Like, I'm not trying to dry needle myself. But when my PT says, hey, I think this is what's going on in the knee, like, I use that and I say, cool, here's what I think reasonable solution would be. And she says yes or no, or she adds on to it. So that's what I hope for you guys. So the 2 disclaimers that I promise. Disclaimer number 1, I'm not a medical professional. I'm not a clinician. I don't do hands-on work. I don't do manual therapy. I don't prescribe drugs. If you are dealing with chronic, clinical, high-end pain, please go talk to someone who is in one of the fields that can help you directly. Also, please don't take anything that I say as medical advice. It is not intended as that. I am a strength guy and a human who's had to figure a lot of stuff out on my own. And I've had a pretty good track record of supporting clients, but I always refer out if someone has pain that is making all movement unmanageable. I always refer out when there is something that cannot be that there's not a strength or movement quality mechanism that we could employ to try to improve things. There's always things that we can't handle. I'm going to tell you one of those stories in just a second. So that's disclaimer number 1. Not a medical professional. This isn't medical advice. This is information based on my experience and my experience with clients. Here's number 2. Sometimes medical professional is absolutely essential. So about a year ago, last winter, one of my clients fell skiing, like hurt her shoulder. It was really sore for a while. We started doing some modified strength stuff for the shoulder, tried to get the shoulder blade moving around better. It got a little bit better, got a little bit worse. And then after probably 3 or 4 months, she finally got in to see an orthopedic surgeon. And orthopedic surgeon said, hey, let's shoot an MRI. I don't know if they did an MRI or an X-ray of it. And what they saw was that the humerus bone, right, the upper bone of the arm, was actually broken. It was broken. There's no amount of strength work that can compensate for a broken bone or fix a broken bone. Bone's broken, it needs to be allowed to heal. Maybe it needs to be set, maybe it needs screws, like whatever it takes. You got to deal with the mechanical thing before you can deal with the strength thing. You have to deal with the hard stuff before you deal with the soft stuff. And so she had surgery and has been recuperating since, and like the shoulder is getting a lot better. And that's our story. So the moral is, though, the lesson is, if it's really, really bad, then getting the advice of a physician, an orthopedic surgeon, a PT, like, again, you're not using them as the solution, but you're using them for information. That MRI provided really essential information. Someone else that I work with who also a shoulder injury, hers had been a tweak while climbing. She fell and kind of hung on a little bit too long and it got a little bit yanked out of the socket. And at least that's how it felt, and that's what she's talked about it as. She'd been to PT. PT didn't help. She'd been to an orthopedic surgeon who just wanted to do steroid injections, and she did it once and then it wore off and stopped helping. And I mean, she was dealing with this for probably about 4 or 5 years before we met, before we started working together. Very quickly after we started working together, I said, I really do want you to go to your ortho and get imaging done. And this was actually prior to the broken shoulder story, pretty close in timeline, but a little before. And I said, look, you really need to go, because what we will do together is work on the movement of the shoulder, the movement of the shoulder blade. We'll deal with the shoulder, we'll deal with quality of around the shoulder. But if there's something broken, if there's something mechanical, or if you have actually like a torn tendon or ligament that would show up on an MRI, it changes the game plan, right? It changes what we can do. It might mean that you need to spend some time in PT before you and I work together. And she went to an ortho, and the ortho did the MRI and said, yep, nothing broken, nothing torn. Things look okay. Your shoulder shouldn't hurt. It's like, well, my shoulder still hurts. even though ortho said it didn't, but the imaging really served to clear it and say that mechanically there was not a reason why we couldn't move forward with this idea of like movement quality and then layer on some strength. So that's what we did. And over the course of 8 weeks, we worked together, we got the shoulder blade moving. There's a YouTube video on that. I think it's Shoulder Success if you want to do a search. I have yet to figure out how to like do the whole linking between videos. I'll get there soon-ish. But you know how to use the search feature in YouTube. I trust you can do that if you want to go see kind of what we did. So, and it's a shoulder success story, is I think what that one's called. But the moral here was we used another professional. We used someone else in a related field who could actually order imaging and read the imaging to basically say, yep, green light, everything's fine. So those are our two disclaimers. One, like if it's really, really bad, please go talk to someone. And I'm not a medical professional, but medical professionals are an essential tool for getting more information and for getting imaging and for getting ideas. But you can't leave it there. If you leave it in the hands of your PT or your surgeon, then you're missing the opportunity to actually learn through this whole experience. And that's the third part of this video, is how do we think about pain as a way of using it to move forward? So I'm going to give you three main ideas here. First one, we want to remember that, and I've got notes over here, so my eyes are off camera for a second. We want to remember first and foremost that pain is a neurological construct, right? We don't have pain sensors in your arm and your tendons and your muscles. You have pressure sensors that detect like pressure on a tissue. You have tension sensors that basically feel how much pulling is happening across a joint, across a muscle or a tendon or a ligament. And then you have some intensity sensors that will actually like indicate like how loud something is. And all of those sensors talk to your brain, to your unconscious brain, and then the subconscious will send messages and information to your conscious brain. A really good example of the difference between the signaling and the response is that if you ever stub your toe really hard and you have someone say, I know the perfect way to make your toe feel better, I'm gonna, if you just let me borrow your thumb and let me borrow a hammer, and I'm gonna like hit your thumb with the hammer really hard. All of a sudden, you're no longer thinking about your toe. Like your toe feels better instantaneously. And what's happening is we're respecting the fact that this nervous system can really focus closely on one thing at a time, and and it's gonna respond to whatever is loudest. So if that's true, then one of the things that we can try to do when it comes to pain is actually de-emphasize the intensity of the response to the sensation. Like if something hurts, it's going to hurt. But if we can actually tune down and turn down our response to that sensation, that's one way of starting to mitigate the impact of pain on our lives. And that's really important because sometimes the pain is no longer about the tissue. When I was working with the climber with the shoulder, like we saw almost immediate pain reduction when we got that shoulder blade moving better, and then the pain would come back. But what happened over the 8 weeks we worked together was that the pain wouldn't come back as loud as it had been, right? So there was this oscillation to it, but those oscillations faded over time to the point where she was able to climb, and she knows if she goes and climbs, like the next day her shoulder is going to be at like a 2 or 3, it's going to be a little stiff, and she's going to have to do some work on it because the strength isn't all there yet, but right, but that pain sensation is definitely on a downward slope, and her activity level is definitely on an upward slope, which is really kind of the goal, right? Like that's where we want to go. We want this to be directional. So the first idea here is that we got to remember that pain is separate from the tissue itself. A tissue can be irritated and a tissue can be like in bad way and actually not show any neurological pain symptoms. In other words, like you could break a limb and like not know it, right? And it's not that the limb isn't broken, but it's that you're not getting that pain response. You could have also broken a limb 2 years ago. It's fully healed, and you might still have some pain response to that because pain can act like trauma a little bit, right? We can push it down. We can and that it can rear its head back up at different times because pain is uncomfortable. Pain is something that most of us don't want to process. We don't want to deal with it. And so it can sit kind of under the layers, under the surface layer, kind of like a trauma can. So the second piece here is thinking about pain from a non-clinical approach. If you go to a physical therapist, you go to an orthopedic surgeon, you say, hey doc, I have pain. They're going to say where, and they're going to try to solve it. And they might solve it with painkillers, they might solve it with a steroid injection, they might solve it with surgery. If it's a PT, they might solve it with heat or e-stim or some manual therapy, some massage. They'll probably apply some strength to it too. But their mission is to alleviate pain. Given that I am non-clinical, I don't alleviate pain. That's not what I do. And in fact, by choosing to not alleviate pain, and it's not that I embrace pain, sometimes in training you do, but it's not that I embrace pain holistically. What I mean is that by deciding that the focus is not on the pain, but the focus is instead on other things that maybe aren't awesome. So, really good example, someone who's got low back pain and is really tight through the upper chest and through the hips, right? They go to stand up and their back hurts because they're like overextended because their hips are too tight and their rib cage is too tight. Well, the back pain there, like the physical therapist is gonna look at the back pain and be like, okay, let's deal with the pain. I look at it and I say, okay, we have a rib cage that's not moving and we have hips that are not moving. Let's get those guys moving and see if that reduces the symptoms of pain in the low back. And even if it doesn't provide an immediate response, if we can start getting the upper chest moving and the hips moving without adding any pain sensation to the low back, well, now we're improving movement quality and we're actually improving our ability to do things, right? And in that way, we're also reducing the trauma response to the pain. And we're almost doing this through the idea of exposure therapy. And exposure therapy, of course, being if you really hate spiders, but you want to get over your hatred of spiders, I might come over to your house one day and be like, I brought a spider. He's in a box in my car across the street. And you'd be like, I hate spiders. Give me a little bit of panic attack, but it'll be fine, right? And next time I come over, I park on your side of the street, and then I park in your garage. I park next to your garage, and then I bring the box inside. And eventually the box goes from being like the far side of the house to being in the same room as you. And then eventually we open the box. And we're like, oh, there's a spider there. And we do that slow enough that you never freak out. We do it slow enough that it never causes a panic attack, but we gently and consistently increase the intensity of that experience into the point which you can have the intense experience but not have the negative response to it, not have the panic attack. And so when it comes to exposure therapy, with regards to pain, often there's something similar that needs to happen, is we need to learn that it's okay for the shoulder or the low back to move. We need to learn that it's okay for the shoulder or the low back to actually even have a little bit of sensation, and knowing what sensation is a precursor to bigger problems, and what sensation is actually just sensation that we've been trying to avoid. Because sensation is not inherently a bad thing, but if you have so much sensation that like the next day something is really, really bad, right? Something is really aching, then at that time it was overdone. But again, we don't want to avoid all sensation. We just need to keep it modulated to what we can control and remain safe. So that's the non-clinical approach, right? Is rather than dealing with the pain, we deal with the things that are around the pain and try to improve them. And then we look to see, and there's some logical chains here, right? If it's an elbow, there's some stuff that we look at wrist and shoulder. If it's if it's the low back, there's things we look at in the hip and the upper back and the shoulders as well. Breathing too. If it's in the knee, we look at the hip and the ankle. And by those mechanisms, PTs might actually work, good PTs will work very similarly. But again, where the PT is going to primarily be asking about how the pain is feeling from a strength perspective and from a movement perspective, the real question is, are these other things that are probably connected to the low back, for instance, are they moving better? And are they moving better without any increase in pain symptoms in the low back or the target area? And if the answer to that is yes, then we are totally winning, right? We're totally winning. And if at some point it's not enough, that's when we can always refer to PT or ortho for another opinion. Last piece. The two tools that I have found to be most useful have been movement and strength. There is not a joint in the body, with the exception of like all the fused joints in the skull because your skull was mobile when you were born to make it a little bit less traumatic on your mom. Like with the exception of like some joints that could move but really shouldn't. Like for the most part, the joints in the body are going to be happier when they move. Joints are controlled by muscles and by tendons and ligaments. And the more appropriate movement joints have, the better they work and the better their blood flow is and the better the blood is into the tendons and ligaments. And that can actually be part of the healing process, is to getting that blood flow. So locking stuff down tends to not be the right solution. Now, can you have too much movement? Yeah, absolutely. We could always, you can bend your elbow far enough the wrong direction and the elbow breaks. Like that's really bad. But that doesn't mean we don't use the elbow at all, right? If the elbow is really stiff, we should be working on is getting the elbow less stiff. Again, without triggering big pain response. And then when it comes to strength comes really in a few varieties. One is, are the two sides of the joint equally strong? Like if your elbow always hurts and you're like, you can do pull-ups for days, but you don't have push-ups because your triceps are really weak. Well, what if we just made the triceps stronger, right? Like maybe that's part of the story. Knees, if the quads are really, really strong, especially if like skiers and hikers and cyclists and runners, if the quads are really, really strong, which they often are, and the hamstrings are really weak, well, now we have some imbalances across the knee. But there's also simply the like pure strength. If you're a skier, are your quads strong enough in order to support you? And if not, then other tissues will start to take load, and we could absolutely see some irritation showing up in the knee because of a lack of strength in muscles. So we have to be careful as we apply these ideas of movement and strength to a joint that doesn't feel good. But it doesn't mean, like just because something doesn't feel great, it doesn't mean that thing needs to rest forever. Movement and strength building are often the best tools. And I'll just put this in one more way of thinking about it. Let's just say you have hurt your knee or you've hurt your shoulder. Go to shoulder, for example, right? And you do some strength work and the shoulder's getting a little bit better, right? And it's getting consistently better. Why would you then decide like, oh, you know what? I want it to go faster, so I'm gonna go to a surgeon. If the shoulder is moving better consistently with strength and movement work, then why not run that course? Because here's the reality. If you start with surgery, you're gonna go to PT, and then you're still gonna need to strength train in order to get back to where you were. PT is not gonna make you strong enough. PT is gonna make sure you're out of pain and that you have a reasonable range of motion. And if you wanna go climb, you've still gotta deal with the strength on that side. And if you had surgery, you've definitely gotta deal with the strength on that side because the surgery is its own form of trauma. But what if on the other end, you go like, all right, I'm gonna start with strength. I'm gonna try to strengthen this thing, and then I'm gonna see how it goes. And if it doesn't go well, right? This was my friend who like had the broken arm. Like the shoulder was responding negatively to what we were doing, and that led her to eventually seeking out the professional advice and like getting the imaging done that could then put her in a position to like change the course and like get the right solution. But if you do surgery, you're gonna do PT and strength at work anyway. So why not actually look at movement quality first? Because here's the bottom line. If you're gonna need surgery at some point in the future, if you're stronger going into that, you're gonna come out of that stronger faster. If you go into that week having taken a bunch of time off and muscles have atrophied, your recovery from the surgery is gonna probably take longer, and your return to full strength for performance is also gonna take a lot longer. Okay, that's it, guys. So big ideas here, just as a quick recap. One, not a medical professional, not a clinician, but what I do want for you is to take ownership and to start to view the people around you, professionals, whether this is PT, ortho, strength guy, yoga teacher, whoever else. We're all resources for you. Own it, use your resources so that you understand what's going on and you can create and execute a plan. Second big thing is remember that pain is not always an accurate indicator of what's going on in a piece of tissue. If you've got an injury from years ago and you still have lingering pain, maybe there's something still wrong, or maybe that is actually a trauma response that's going to respond well to some exposure therapy. Last here is consider taking a non-clinical approach that puts strength and movement quality first into the treatment plan. And remember, the goal is not to deal with the pain so much as it is to increase the things you can do and the strength with which you can do those in all of the places that don't hurt, and not make the pain any worse. And then to see over time, over the course of 6-8 weeks, maybe a few months, do you get the directional response that you want? But as always, if the pain is so strong that you cannot move, that it is debilitating for everything that you do, please seek out a medical professional. And then when you're ready, know that applying strength and movement quality is going to be part of that trip. And in all honesty, if you do strength and movement quality work and it doesn't make things worse, odds are that in some way it's going ahead and making things better. Thanks for tuning in. You guys have a wonderful, wonderful day. I'll see you next time.